Bismillahirrahmanirrahim. My name is Dr. Muhammad Naseem Shirzad, and today I am going to present one of the urological emergency, and that is the testicular torsion. Testicular torsion can be defined as the twisting of the spermatic cord that resulting in the strangulation of the blood supply to the testes and epididymis. Testicular torsion can occur at any age, but the most common age of presentation is 12 to 18 years, and the irreversible ischemic injury of the testicular parenchyma may begin as 4 hours after the occlusion of the cord, and there is an irreversible loss or necrosis of the testis after 24 hours. So now let's discuss the presentation, what point to be asked in the history and examination. The point to be asked in the history is the time, nature and activity at the onset of the pain, and that is upon waking up from the sleep. Asked about any previous similar episode of torsion that may be a suggestive of intermittent torsion. Also asked about any previous scrotal surgery. Then the patient present much of the time with the sudden unilateral scrotal pain, and that is referred to the iliac fossa. The patient is also complaining of nausea, vomiting, abdominal pain, and fever. Now, on examination, the testis will be tender on the affected site, and there will be erythema or edema, and this we call it as the gear sign. Now, let's discuss the cremasteric reflex. The cremasteric reflex is having a root value of L1 and L2. The cremasteric reflex is elected by stroking the medial side of the thigh, and that's leading into the ipsilateral contraction of the cremasteric muscle, and that is bringing the testis closer to the external inguinal ring. This cremasteric reflex is usually absent in the testicular torsion, and this is absent because there is a edema of the cremasteric muscle. That's why it is absent. And when it is present, then better to rule out other causes of acute testicular pain. The second important things that the absence of this cremasteric reflex is also called a Rebno-Wett sign. So the sensory component of this cremasteric reflex is by the ilioinguinal nerve, and the motor component of this cremasteric reflex is by the activation of the genital branch of the genitofemoral nerve. Now let's discuss the apparent sign, and the apparent sign mean is the relief of pain after the elevation of the testicle with the hand. This apparent sign is negative in case of testicular torsion, and negative means when we elevate the testis there is no pain relief in case of testicular torsion, but there is a pain relief in case of epididymoarchitis. But again, this is not a reliable sign to differentiate both testicular torsion and epididymoarchitis. The other things, the testis will be high riding, and this is called as the bronzal sign. And the next finding, that is the horizontal lie of the testis. The initial episode in the testicular torsion, that the testicles rotate on the spermatic cord, and initially when it is 180-degree rotation, it lead in first into the venous occlusion, and that's leading into the edema. But when it occur into 360 and even 720, that's leading into the complete obstruction and leading into the arterial ischemia, and that's leading into the infarction. So two important factor is important. One is the degree of torsion. The higher the degree, the more is the risk of loss of the viability of the testicle, and the second is the duration of the torsion. As the more time is elapsing, it lead into more loss of the testis, and when it is more than 24 hours, that lead into testicular necrosis in most of the patients. Now let's discuss the two types of testicular torsion. Testicular torsion is of two types. One is the intravaginal torsion, and the other is the extravaginal torsion. The differentiation of these both is important. The testicular torsion that are taking inside the tunica vaginalis, that is called the intravaginal, and those which taking outside, that is called the extravaginal. And the distinction is important because the two forms of torsion are associated with different age of presentation and etiology. So let's first discuss the intravaginal torsion. There are three important things to be remembered for intravaginal torsion. Number first, it is the most common type, around 90%, and it is occurring most commonly at puberty. The third, that it is most commonly associated with anomaly called the bell clipper deformity. What is this bell clipper deformity? The understanding of this concept is important to understand even the intravaginal torsion. We know that the bell clipper abnormality is actually the malformation of the process vaginalis. Normally what happening? Normally the tunica vaginalis attached directly to the posterolateral part of the testy. It means that the tunica vaginalis is not completely surrounding the testy, but it is just attached onto the posterolateral part of the testy. With the bell clipper deformity, the epididymis, the distal spermatic cord, and the testes that are entirely surrounded by the tunica vaginalis. So this allowing the testis to hang freely with the ability to turn and swing inside the tunica vaginalis, as I have shown in the picture, that the whole testis along the distal part of the spermatic cord and the epididymis, that is whole under the sac. So the testis is freely hanging and swinging inside the tunica vaginalis, and thereby this predisposes the individual to testicular torsion. The second type of the testicular torsion is the extravaginal torsion. The extravaginal torsion is most commonly occurring in the children, and it is not associated with bell clipper deformity, and it is not very common. And the etiology of this extravaginal torsion, and it is thought that it is result from the poor or very absent attachment of the testis to the scrotal wall, and this allowing the rotation of the testis, epididymis, and tunica vaginalis as a unit, and this causing the torsion of the cord much of the time at the level of the superficial or external inguinal ring. So the extravaginal torsion most commonly seen in first year of life. Now let's discuss the investigation of the testicular torsion. Testicular torsion, number first, it is a clinical diagnosis, and the gold standard management for any type of suspected testicular torsion is the urgent scrotal exploration. And it is much more important that the use of radiological investigation should not delay the patient transfer to the theater. So the patient should be transferred and should not be delayed because of the radiological investigation. So now let's discuss the Doppler color ultrasound. The Doppler color ultrasound has a role in those patients where clinical features are equivocal and there is no clinical indication for the urgent exploration. So in such a patient, we can go for ultrasound, and ultrasound is showing in a complete torsion is the complete loss of blood supply, and it's showing a specific sign which is called the viral fool sign, and it is a spiral like pattern that is twisting the spermatic cord, and it is shown by the high resolution ultrasound. There is one scoring system which is called the twist scoring system, and it is means T for testicular, W for workup, and IST means for ischemia and suspected torsion. A clinical decision tool, this is a clinical decision tool, and it determining the risk and thus is decreasing the indication for ultrasound. So the understanding of this twisting scoring is important. It is divided into 5 components. Number first is the testis swelling, which is having 2 points. If the testis is hard, it is having again 2 points. Absent cremasteric reflex is having 1 point. Nausea and vomiting is having 1 point. High riding testis is having 1 point. So a score of 0 means that this is 100% negative predictive value, and a score of 6 to 7, that is the highly predictive of testicular torsion. So that's why it is important. And if it is a score is between 0 to 2, it means it is a low risk, and the 100% negative predictive value for torsion, and generally no ultrasound is required or urological consultation is required. A score of 3 to 4, it is intermediate risk and the ultrasound is warranted. And a score of 5 or above, it is a high risk patient and there is a 100% predictive value for torsion. Ultrasound is not required, urgent urological consultation and surgery required to salvage the testicle. So this division into high risk, low intermediate risk, and low risk is important. Low risk 0 to 2, intermediate risk 3 to 4, and high risk is 5 or more, and that's need urgent exploration. The next important investigation is radionuclide scanning or scantiography of the testis. This is one of the most accurate imaging technique but we are not performing it routinely because it is not readily available, and secondly, it is a time consuming procedure. So, what are the differential diagnoses of testicular torsion? The differential diagnosis of testicular torsion include epididymoarthritis, which can be differentiated on prime sign. We elevate it, the pain is relief in the epididymoarthritis, but not in case of testicular torsion. The other is the traumatic swelling, the torsion of the testicular appendix, strangulated hernia, hydrocele, varicocele, and testicular tumor. Now let's discuss that what are the difference between acute epididymitis or epididymoarthritis and testicular torsion. The pain in acute epididymitis or epididymoarthritis, the pain is gradual onset, and that is for many days, while in case of testicular torsion, the pain is sudden in onset, including in hours. The cremasteric reflex is normal in epididymoarthritis, but that is abnormal. I means that is absent in testicular torsion. Usually there is no nausea and vomiting in case of epididymoarthritis, but there is nausea and vomiting common in testicular torsion. Acute epididymoarthritis most common in sexually active men, and the testicular torsion is most common in children of 1 year age or adolescent, and in a man without evidence of any infection or inflammation. Secondly, the history and physical examination support a diagnosis of urethritis or urinary tract infection in case of acute epididymoarthritis, but the history and physical examination don't support a diagnosis of urethritis or UTI in case of testicular torsion. The empirical treatment and follow-up is required for acute epididymoarthritis, and the testicular torsion is surgical emergency. Now let's discuss the treatment of testicular torsion. Testicular torsion is a surgical emergency, and the gold standard treatment for testicular torsion in case of suspected torsion is immediate surgical exploration, and imaging is contraindicated in case of suspected testicular torsion, and the patient should be shifted to the OT in order to prevent the necrosis or death of the testis. Now, in case of a patient having intermittent torsion, in that case the patient need a bilateral archidopexy electively. So, for intermittent torsion, elective bilateral archidopexy is required. Now, in a patient, what is the role of manual detorsion? Manual detorsion is done like opening the book. How we are opening? We are opening the book from medial to lateral. That's leading to detorsion. And this manual detorsion can be attempted for intravaginal torsion if the operating facility is not immediately available or accessible, and this is done by attempting to externally rotate the testicle just like opening the book. Even if the testicle is detoured, and the patient must need bilateral archidopexy, and that should be performed in order to prevent the further episode of the testicular torsion. So the most important things for surgery is the counseling of the patient, and the patient should be fully counseled regarding the need of archidectomy, and the consent for archidectomy plus archidopexy should be taken. The patient should be counseled regarding the risk of infection, post-operative risk of infection. The patient should be counseled regarding the infertility, and the patient may need a long-term hormone replacement. So the patient should be counseled before shifting into the theater, and a proper consent should be taken. Now, regarding the surgical approach, a midline rep incision or bilateral transverse scrotal incision given, then we will enter into the ipsilateral scrotal compartment, then we will incise the tunica vaginalis, and then we will deliver the testicle for examination. The spermatic cord is then untwisted, and after untwisted, we will be looking for the viability of the testis. If the testis is viable, then we will straightforward go for archidopexy, and archidopexy should be performed bilaterally. If the viability is still in a question, then place the testis in some warm sponge for few minutes, and then re-evaluate after several minutes. The sign of viability after re-evaluation include the return of the colors, and the return of the Doppler flow. So we can perform ultrasound which is easily available during if the viability is in a question, and then we can give a prick on the testis, and that's if giving a fresh arterial bloods, and it means that the testis is viable. So these should be done for evaluation. In order to prevent the subsequent torsion, we will must fix the other testis. Most commonly, we are fix the testis with 30 PDS. At 3-point fixation is usually recommended, and the fixation is performed on the medial, lateral, and anterior-inferior portion, and it is placed in the dartus pouch, into which the testis is performed. So the contralateral arcadopexy is always performed when the testicular torsion is confirmed intraoperative. And if the testis is necrotic and there is not viable, then better to perform arcadopexy, because this can lead into, if you leave as such, this can lead into the formation of spermatic anti-spermatic antibody, and that can lead into infertility, because we have lost the testicular barrier. That's why it's better to perform the arcadopexy if the testis is not viable.